Welcome back. Sorry for the small interruption. We'll start back nevertheless. Okay. So in the same area, like you can suspect a meningitis or probably even a meningoencephalitis in that setting. So how can I think about predominant meningitis or meningoencephalitis is by seeing whether I'm having prominent phonological deficit and cortical symptoms and signs. So if no, if not much of FND is seen, not much of cortical symptoms and signs are seen. So in that setting, usually I'll suspect a viral meningitis or a aseptic meningitis. So if yes, it must be either an acute bacterial meningitis called as ABM, or it must be a meningoencephalitis, usually. That's my primary suspicion here. So of course, to confirm this suspicion, I need two. One is I need imaging, and second is I need lumbar puncture. What to do first, whether imaging you will do first or lumbar puncture you do first, will be further decided based on my criteria called FAILS. I usually use this FAILS criteria. So F stands for phonological deficit, A stands for altered mental status, I stands for immunosuppression, L stands for some lesion, S stands for seizure. So let me write it. So F stands for phonological deficit, A stands for altered mental status, I stands for immunosuppressed patient like HIV or on chemotherapy, L stands for lesion. I'm talking about a space occupying lesion, known case already in the brain, or seizures, presence of seizures. So whenever fails no, then I can proceed with lumbar puncture directly. Whenever any one of this is there, anyone, if it's there, then in this setting I'll be doing a CT first. And CT is normal, or they are not showing any signs of raised ICP. No signs of raised ICP. Then in this setting, I'll be proceeding with the lumbar puncture. If CD is showing some changes, then I'll be treating accordingly. So how I'm going to go about with the lumbar puncture now? So everyone would have studied that basic table that is given in all microbiology textbooks. I'm not going to tell that here. So how to proceed lumbar puncture? The first thing I need lumbar puncture is the cells, the cellular count and the differential count of the cells. That's what I want. So in this, if I'm seeing predominantly neutrophils, or I can see predominantly lymphocytes, lymphocytic effusion. It's predominantly neutrophils, especially if the neutrophil count is more than 1,000. In this setting, I can make a concrete diagnosis of acute bacterial meningitis. If the neutrophil count is less than 1,000, the specificity of ABM will be less. But still, if a patient has received antibiotics already, in the sense like somebody can have a fever for 1 or 2 days and they would already receive some empirical antibiotics in the outside hospital or local practitioner. In that setting, even less than 1,000 becomes significant if they received already antibiotics. If not, classically, if it's more than 1,000, it is acute bacterial meningitis unless proved otherwise. If it's predominantly lymphocytes, then in this setting, I need to see the glucose. Glucose may be reduced or glucose may be normal. If glucose is reduced, I have two possibilities now. Either it could be a TB meningitis or it could be a cryptococcal meningitis. In both this setting, my glucose will be low only. If glucose is normal, my typical diagnosis will be viral meningitis or probably some autoimmune or possibly some, different kind of a meningitis, which we'll be discussing after some time. So completely different or other causes. If the glucose value is normal and a predominantly lymphocytic CSF. So now to rule out this, I need an MRI. Hereafter, I cannot be without imaging. I definitely need MRI here. In MRI, I have to see whether it's a gray matter lesion or predominantly a white matter lesion. If my problem is predominantly in the gray matter, I'm probably dealing with an encephalitis for sure. And it must be some viral encephalitis. For example, if my involvement is predominantly in the temporal lobe, I'll be thinking about a herpes simplex encephalitis. Or if my involvement is predominantly in the basal ganglia or the thalamus, in the subcortical areas, because gray matter and thalamus are also, basal ganglia and thalamus are also gray matter only. So if I see predominantly there, this is quite non-specific in the sense like like it can be seen in many other viral encephalitis, like Japanese encephalitis, even you can get that with the Nipah virus encephalitis. So many viruses can produce basal ganglia and thalamic lesions. So that's going to be absolutely non-specific. Or third possibility is in the periventricular region. If I'm seeing typically, it will be more of a cytomegalovirus, the periventricular gray matter, cytomegalovirus. Or if it's predominantly white matter, in exam only two possibilities mostly. If white matter lesions are the dominant one, think about either it's a PML, that is progressive multifocal leukoencephalopathy, versus ADAM, that is acute disseminating encephalomyelitis. That's going to be really, really important. Usually, you know, where ADAM will happen, ADAM will be typically seen in the setting of a children post-viral infection or a post-vaccination. They will have cerebellar issues. I told you already. So that is where you're going to diagnose ADAM, and there is a separate diagnostic criteria. And most often the changes will be asymmetric here. ADAM. As far as PML is concerned, typically you will get in the setting of HIV with a CD4 of less than 50, or a patient who's having multiple sclerosis on natalizumab. So you can suspect a PML, progressive multifocal leukoencephalopathy. The only diagnostic standard is the CSF, where you will see JC virus PCR positivity. That's one way to find out progressive multifocal leukoencephalopathy. Or in MRI, you will be seeing a kind of non-enhancing white matter lesions. These are demyelinating, non-enhancing white matter lesions, and with no mass effect, and they will not cause any mass effect. I'll tell you the importance of each and every point in some time. So this is how you're going to diagnose a PML. So PML will have some classic history. Background history will be there, like HIV or MS or natalizumab. These are classical history. And ADAM will have completely different picture. Children post-vaccination or post-viral coming with predominant cerebellar problems and cognitive dysfunction. Asymmetric white matter, similarly, they'll be non-enhancing as well. Asymmetric white matter, poorly enhancing lesions, in both the sides of the brain. So think about a ADAM, acute disseminating encephalomyelitis. On the other hand, you can have autoimmune encephalitis also. Remember, if still you have done so many things, so much you have done, but still no clue, think about autoimmune encephalitis. Autoimmune encephalitis possible. Autoimmune encephalitis can be of many types. It could be something called anti-NMDA receptor encephalitis, or it could be a paraneoplastic syndrome, like anti-TR antibody, anti-Yo antibody. We have so many types of antibody which we'll be discussing. So paraneoplastic encephalitis could be there. So our third possibility could be something called a Hashi encephalopathy. That's called a steroid responsive encephalopathy. That's called Hashi encephalopathy. All the three possibilities are there. So how to diagnose? Here, anti-NMDA receptor antibody will be positive. There's a high degree of suspicion. And the paraneoplastic syndrome related encephalitis will have underlying cancer. That's a clue here. And sometimes encephalitis can present before a diagnosis of a cancer. So you have to be a little careful there also. But anyway, in exams, it will be relatively simple. You'll have some underlying cancer for sure. But more often you test for antibodies. And there are many antibodies out there, which we'll be discussing subsequently. And Hashi encephalopathy, typically anti-TPO will be in extremely high titers. Remember, this is not the diagnostic criteria. Remember, it's a diagnosis of exclusion. You have to be very clear about that. You cannot diagnose Hashi encephalopathy based on just anti-TPO antibodies are positive. Anti-TPO antibodies can be elevated in majority of us, even without thyroid disease. So you cannot make a diagnosis based on anti-TPO if there is no other cause, no clue for the encephalopathy. And if anti-TPO antibodies are in high titers, then in that setting, you can diagnose a Hashi encephalopathy. So usual treatment of all these autoimmune encephalitis will be steroids and IVIG. So you have to start late. Steroids and IVIG, that's going to be the usual treatment. As far as this kind of viral encephalitis is concerned, I'm going to treat with typically antiviral drugs. What are the antiviral drugs I can prefer? For that matters, for herpes simplex encephalitis, I'll be using acyclovir, of course. The dose is 15 milligram, 10 to 15 milligram per kilogram, 3 times a day. and I have to give for 14 days. That's the standard dose of acyclovir for HSV encephalitis. Other viral encephalitis depends. We don't really have any idea. For CMV, I can use ganciclovir. Ganciclovir, of course, the treatment of choice for any disseminated CMV infection, IV ganciclovir. And this kind of JC virus related infections can be probably treated with reducing the immunosuppression. For example, if it's HIV patient, you give heart, or you start with stop natalizumab. Stop natalizumab, which means you have to boost the immunity. That's the most important. Immunosuppression is the reason for developing JC virus related PML. So you have to boost the immune system by either starting highly active antiretroviral therapy or stop natalizumab. Plus or minus, you can use cidofovir, which is probably the only drug that is effective against polyomavirus group, JC virus and BK virus. Or ADAM, I'm going to use with steroids. So that's the treatment for ADAM. And now we have not yet discussed on the two giants, that is the TB meningitis and cryptococcal meningitis. As far as TB and cryptococcal meningitis is there, you need to differentiate both these things. So where will you diagnose TB and where will you diagnose cryptococcal meningitis? So remember, TB will be more often a subacute to chronic disease. It will not be very acute. And more often TB will have constitutional symptoms. We know that, like fever, weight loss, will be happening for quite some time. So that's how TB is going to come. And some patients, not all patients, like 30 to 50% of the patients will have chest X-ray lesions, which means chest lesions will be there. You can screen with a chest X-ray or a CT, you can find some lung disease, because as far as Mycobacterium tuberculosis is concerned, lung is always the primary site of involvement. Other organs is always a sign of dissemination. It comes from the lungs only. So lung disease can be overtly seen in 30 to 50% of the cases. So that screening for lung disease is very important in this setting. And more often they will have cranial nerve palsies. And most common cranial nerve paralysis, again, cranial number 6. And if you take an imaging like a CT or an MRI, typically you will be seeing basal exudates. That's the key here. Basal exudates, plus or minus you can have obstructive hydrocephalus. Because of the exudates, because TB produces tremendous amount of proteins, so that can get occluding in the basal areas of the brain. So that's called basal exudates. And together, because of the occlusion of the outlet of the CSF, you can result in development of obstructive hydrocephalus also. And of course, CSF analysis is very important, where ADA levels will be elevated, typically more than 40. And you will see a predominant lymphocytic effusion with a lot of proteins as well. So that forms something called a cobweb coagulum. Everyone knows that. What I mean by cobweb coagulum, you should have studied in microbiology itself, so I'm not going to write it once again. And gene expert may be positive. It's called a CB-NAT, may be positive. And remember, gene expert is approved in CSF, but gene expert is not approved in pleural fluid or ascitic fluid or any other fluid, pericardial fluid also. But gene expert is currently approved in CSF as an add-on investigation. But remember, yield of AFB and all is very poor. You cannot see the Bacillin AFB stain. Very, very rare to see AFB. And culture, again, yield is very poor. The only way to diagnose is based on this kind of subtle signs. This is how you diagnose a tuberculous meningitis. As far as, and even new investigations are coming, like MR spectroscopy. That's also, to a decent extent, they can differentiate tuberculosis, but that is very important setting of a tuberculoma rather than a tuberculous meningitis. Here we're talking about tuberculous meningitis, we are not talking about tuberculoma. So MRS will be less useful, but still I told MRS because tuberculomas can be easily diagnosed with MRS based on the choline peaks and the lipid peaks they have. And as far as cryptococcal meningitis is concerned, very commonly it will be in immunosuppressed individuals, HIV, CD4 less than 150. So in that setting, you will get a cryptococcal meningitis. And most of them will have an extremely high CSF opening pressure, like 30, 40, 50, high CSF opening pressure due to unknown reasons. And at the same time, you have to know that the primary site is again the lungs only. Meningitis is always, CNS spread is always a sign of dissemination. It's almost always a sign of dissemination. Primary site is always the lung for Cryptococcus. So that is the reason why the best investigation that you can do is a CRAG. CRAG is nothing but a cryptococcal antigen assay. CRAG, cryptococcal antigen. So you can do in the serum or you can do in the CSF both, but nevertheless, CRAG is very important and it's a sign of dissemination. So which means whenever you have a serum CRAG or a CSF CRAG positive, which means the bug that should be within the lung has disseminated now to the brain. So that is the idea. So that's why CRAG is a very important and one of the very good investigations because it's having a very high sensitivity and specificity. And of course, you can do staining CSF also, but yield is very poor, where I'll be using something called India ink staining, or for any fungus, I can use something called a GMS stain. GMS is Gomori methanamine silver. India ink stain. India ink stain, you know, it's a negative stain, which means it's not going to stain the organism. Instead, it will stain the background. And this Cryptococcus contains a capsule, you know that. And in India ink stain, the capsule will not be stained, but all other things will be stained, so that because the background is completely stained with black and the Cryptococcus capsule alone is not stained, so that capsules will look and stand out in the background. So that's why it's a negative stain. It's not a kind of a positive stain. And GMS is a positive stain. That's called a Gomori methanamine silver stain. And one of the important words, keywords, and the clue that is associated with an exam with regards to this cryptococcal meningitis is the soap bubble appearance. In MRI, you can see this. In like in gross pathology, you can see this. Even in GMS stain, you can see this. That's very characteristic. Even India ink stain, you can see this, called a soap bubble appearance. Whenever they give this kind of word in exam, it always means it's a cryptococcal meningitis only. As far as treatment is concerned, cryptococcal meningitis typically is treated with azole therapy. Along with, you can give flucytosine. Typically, you can use amphotericin B plus flucytosine. This is a classic gold standard treatment for cryptococcal meningitis. As far as TB is concerned, it's going to be antitubercular drugs, ATD, antitubercular therapy. So this is going to be the basic treatment. And how long, how to give, we'll discuss later on. Not now, in CNS. So this is how you differentiate between a TB and a cryptococcal meningitis. Many times it will be confusing, but the keywords will be very simple. Soap bubble, basal exudates, obstructive hydrocephalus, elevated ADA, gene expert, and the chest lung disease, and CRAG, and very high opening pressure. So these are the keywords. That's why I told you. So that's how the examiner wants to make you go towards the diagnosis of TB or a cryptococcal meningitis. Finally, like acute bacterial meningitis, it depends on the organism what you're going to treat. So we'll be discussing after some time. So I think this table will be a very, very easy table for you. So how to approach a patient with a fever and a headache. So any patient who's having a fever and probable headache, when you're suspecting a meningitis or meningoencephalitis, look whether this is there or not. Predominant cortical symptoms and predominant altered mental status, predominant focal logical deficit. Go towards a ABM versus meningoencephalitis. Then you're going to attempt based on that. If CT is showing some space occupying lesion, then that's a different game. So you have to characterize the space occupying lesion and you have to see whether it is ring enhancing or non-ring enhancing lesion. In exam, the ring enhancing lesions are very, very like commonly asked questions. It's an examiner's favorite. So what are the types of ring enhancing lesions you see and what are the differential diagnosis for ring enhancing lesions? Can anyone tell what are the differential diagnosis for ring enhancing lesions? You have 4 to 5 differential diagnoses in CT. So the first, of course, is the brain abscess, correct? Then what else? Apart from brain abscess, you have toxoplasmosis. Number 3, you have primary CNS lymphoma. Could be ring enhancing, especially in immunosuppressed individuals like HIV patients can have ring enhancing lesions and can get with tuberculoma. Tuberculoma can have ring enhancing lesions, and of course, we have neurocysticercosis. So characteristic ring enhancing lesions, each and everything has to be differentiated. So previously, like many older neurology textbooks will give, these are the tumors of neurological origin. I mean, they call it, tumors of infectious origin, not neurological, tumors of infectious origin, which means they can mimic a tumor, but they are of infectious origin. But right now, I mean, you don't need to remember those names and all. It's always a DD for ring enhancing lesions are very, very, very important. I think this must settle the debate. I've told you right from your, like viral meningitis to bacterial meningitis, everything we have discussed. So what is the primary issue? So, I mean, you will anyway know that kind of a table that's given all microbiology textbooks. So that's not a key here. So all the key points, whatever it is, I've told you. So if you understand, we can move to the next thing. Do you understand? Yes, quite simple, cool. It's not a big deal at all. To differentiate what are things that you're going to see. So the next step is, what is the empirical treatment? So any patient who's coming with a problem, meningoencephalitis. So what is the empirical treatment you give? Of course, the first antibiotic that you need to give is zone. I mean, in the sense like I'm talking about a ceftriaxone. That's the first antibiotic you're going to give, plus or minus others. So, and second important one is acyclovir. Will start with almost all patients because there is always a possibility of herpes simplex encephalitis. Other things are add-on. For example, I can start with what is that? Ampicillin. Ampicillin can be started if patient is age more than 50 or if a patient is an immunosuppressed patient, like HIV patient. So in that setting, I can start empirical ampicillin also. Why I'm starting with empirical ampicillin? This is for listerial cover. Because I told you extremes of age immunosuppression is always a problem because they can have underlying listerial infection. So listerial cover. So for that I can add ampicillin. Ampicillin is one of the very good drugs for listeria monocytogenes. So this is the best empirical treatment I can start with. But remember, when I'm starting with ceftriaxone, I have to start double the dose. So usual dose of ceftriaxone is 2 gram IV OD. But in the setting of meningitis or meningitis, I have to give 2 gram IV BD because that's a meningeal dose, double dose, to make the antibiotics move into the blood-brain barrier better. As far as acyclovir is concerned, that's the standard dose, 10 to 15 milligram per kilogram, 3 times a day. That's the standard dose I'll give. Depending on the PCR results, I can continue or I can stop the acyclovir also. So it is the empirical treatment I start with. Suppose if the patient is having a post-neurosurgery infection, some brain infection. So in this setting, I'll be typically starting with piperacillin tazobactam. I mean, I have to give a pseudomonal cover. Basically, that's more important because I need some pseudomonal cover. For giving a pseudomonal cover, I can start with piperacillin tazobactam. One important thing, or I can start with the cefepime, or I can start with ceftazidime, or I can start with the meropenem also. Meropenem as well. So any one of the drugs I'll be giving. Plus, along with it, I have to give a staph cover. For this, the best choice will be vancomycin, 1 gram IV 2 times a day, depending on the renal function. So I need to give staph cover. So one pseudomonal cover, one staph cover must be enough for most of the post-neurosurgery infections, which means any one of this plus vancomycin. That's for staph cover. Suppose if the patient is having a brain abscess, abscess can be coming from different areas. For example, if it's a sinus infection, usually I'll get abscess in the frontal area, frontal lobe region. And if it's a ear infection, like otitis media, I'll get abscess in the temporal region. Or I can get due to systemic infection. Very commonly, it will be due to infective endocarditis, systemic bacteremia. So in this setting, the location is variable, even though I'll be getting more in the parieto frontal region maybe. So that's the usual location. Again, it will be in the MCA territory. Any embolus, I don't know why they have so much affinity towards MCA, so they will reach the MCA territory only, very commonly in the parieto frontal region. That's where you're going to reach, in the superior division of the MCA. That's where you commonly get the embolus causing brain abscess. So whatever may be the case, the problem with brain abscesses, they might be polymicrobial. Whenever I use the word polymicrobial in medicine, it always means they have anaerobic risk. Anaerobic infection risk is always there. So I have to give some treatment regimen that can cover up the anaerobic organism. So typically I start with the ceftriaxone, possibility number 1, plus I'll be giving a metronidazole also. So this is if it's a sinus or a ear infection. Sinus or ear infection. If I see a underlying infected endocarditis, then same regime as that of infected endocarditis must be enough. So I think we have discussed extensively on how to treat infected endocarditis. I've given all the antibiotic regimens as possible already in the cardiology section, so I don't think there is any need to repeat there. If it's suspecting a ear or sinus infection, then this regimen must be enough. On the other hand, if you are suspecting infected endocarditis, because of that you are having a brain abscess or systemic infection, depending on that, you can treat the patient. Not a big deal. So fine. So post neurosurgery. And is there any role for dexamethasone? Dexamethasone, answer is yes. So as an empirical treatment, we start with dexamethasone also. And how long you have to give dexamethasone? Usually you can give by approximately 4 days. 4 days of dexamethasone may be needed in acute bacterial meningitis. Most effective if it's pseudomonas. Sorry, if it's pneumococcus. If it's pneumococcus, it's very effective to reduce the meningeal inflammation. Other areas it can be effective, but depends again. So, but it's very, very effective in the setting of pneumococcus, where it is clearly proven in multiple studies. The dose of dexamethasone varies, but in general, they suggest a dose of 0.4 milligram per kilogram. That's the dose they suggest basically, or 10 milligram 4 times a day, or 3 to 4 times a day is what the dose of dexamethasone they suggest, but depends again. So you can give dexamethasone for the first 4 days. After that, it has no purpose. First 4 days, you can add dexamethasone in a case of a suspected acute bacterial meningitis. Possible. So empirical treatment, we know. And the first drug, if they ask you to start with in a meningitis, that's always a ceftriaxone. And post neurosurgery, we know. Abscess, yes, I told you what is the treatment. And nocardia. If they talk about nocardia, think about a TMP-SMX, cotrimoxazole. Trimethoprim, sulfamethoxazole, cotrimoxazole. If you think about a nocardial infection. So whenever they say antibiotics have been given post-transplant patient not responding properly, more of a brain abscess kind of a scenario, because nocardia causes more of abscess rather than meningitis. If you're encountering an abscess kind of a scenario in a post-transplant individual, high suspicion of nocardia in exam, so very notorious. So go for the cotrimoxazole as the answer in this setting. Okay, treatment is done. Then as far as HIV patients are concerned, there are 3 diagnostic possibilities that you have to be very clear about. So one is going to be the toxoplasmosis, and second is the primary CNS lymphoma. We are talking about HIV and related neurological infections. So CNS lymphoma. And third one is the PML, progressive multifocal leukoencephalopathy. Remember, usually toxoplasmosis can happen at any CD4 less than 200. Primary CNS lymphoma, again, CD4 less than 100. PML, CD4 less than 50 usually. So depending on severity. But nevertheless, all these 3 things are going to happen, like in the setting of HIV. So you have to differentiate each and every of them. As far as toxoplasmosis is concerned, the most important problem will be the phoconeurological deficit and headache, because toxoplasmosis really produces a mass lesion in the brain. They'll behave like a mass lesion in the brain. So they'll be mostly having phoconeurological deficits, headache, seizures, and plus or minus they can have fever. So that's how they're going to come, toxoplasmosis, when they're going to present. CNS lymphoma, the presentation is very variable. Still, they can have a phoconeurological deficit, they can have headache, but very rare to have a seizure as far as CNS lymphoma is concerned. Typically, they don't have a fever, and presentation is highly varied again. As far as PML is concerned, toxoplasmosis will be more acute in nature. Whereas primary CNS lymphoma, variable, it can be acute or subacute in nature. Whereas PML will be more subacute in nature. More subacute in nature. They'll be having more of a cognitive dysfunction, behavioral issues, more than a phoconeurological deficit or more of a headache. They'll be having cognitive dysfunction, behavioral issues. That's the most important. Okay. Ankit is asking cryptococcus. No. We are talking about HIV, neurological management, mass lesions in the brain. Mass lesions in the brain. Okay, fine. We are not talking about meningitis here. So anyways, this is going to the clinical picture, but anyway, clinical picture will not give a good clue most of the time. So that is why we go for imaging. So what will you see in imaging basically? In imaging, I'm going to see multiple ring enhancing lesions. In contrast CT, I'm going to see multiple ring enhancing lesions, and it will be multiple usually. Very commonly in the basal ganglia, thalamus, and in the juxtacortical location. Next to the cortex, juxtacortical location, basal ganglia, thalamus, and these are the areas where you're going to see this multiple ring enhancing type of lesions. And as far as primary CNS lymphoma is concerned, most of the time it will be in HIV. We are talking about HIV. Remember, the morphology can be different in non-HIV individuals. In HIV, you will be seeing a kind of a lobulated ring enhancing lesion. It may not be solitary, and be lobulated ring enhancing kind of lesion, typically seen in the frontal white matter. Very common in the frontal white matter. That's a common location of a primary CNS lymphoma. As far as PML is concerned, you'll be seeing more of a white matter, demyelinating lesions. Typically, they'll be non-enhancing. They'll not enhance at all, and they will not have any mass effect, with no mass effect whatsoever. But that's one important difference, because these two can have mass effect, which means surrounding edema, midline shift can be there. But definitely PML will not have any mass effect. It's only a discrete white matter lesion that is present in the brain. Definite diagnosis can be made only by biopsy. If you do a biopsy, what are you going to see? Tachyzoids of toxoplasma. That confirms the diagnosis. As far as primary CNS lymphoma is concerned, we are going to see more of this thing, what small blue round cells. I can write SBRCT. So you'll see a tumor that is made of small blue round cells. That's what called a small blue round cell tumor. And these are nothing but aggregations of lymphocytes. I'll come back to that in some time. If they ask you the most common type of lymphoma that you see in HIV patient, that is DLBCL, and this will be of more of an immunoblastic phenotype. Immunoblastic type of DLBCL, that's what you see in the setting of HIV patient. Usually it is associated with EBV. So EBV positivity will be there. 95% of the primary CNS lymphoma that is associated with HIV patients will be Epstein-Barr virus positive. So that's why the EBV positivity is important. Remember, most of the features, whatever I told you, will be different for a sporadic primary CNS lymphoma. Because sporadic primary lymphoma may not be ring enhancing at all, may not be lobulated at all. It will be discrete solitary lesion with diffuse enhancement will be there. And it may not be EBV positive, and only 10 to 20% will be EBV positive in the setting of a primary CNS lymphoma happening in immunocompetent individuals. So immunosuppressed individuals only will get this kind of typical presentation. And you don't really do a biopsy. Why you want to do a biopsy for a white matter lesion? It's like multiple sclerosis. Why you want to do biopsy here? Absolutely, you don't want to do biopsy for a PML. PML is straightforward imaging diagnosis itself. CSF, you can do a toxoplasma IgG, which can be elevated, which is reasonably specific for the diagnosis of toxoplasma. And you don't really see anything in the setting of a primary CNS lymphoma. But here you can look for the JC virus PCR, which will be positive usually in PML, progressive multifocal leukoencephalopathy. As far as treatment is concerned, here you're going to give that pyrimethamine and sulfamethoxazole combination. I generally call it as a SP combination. Sulfamethoxazole and pyrimethamine. Sulfamethoxazole and pyrimethamine combination. For primary CNS lymphoma, I'm going to use steroids, because in lymphoma, dexamethasone forms a very integral part of the treatment. Plus, I can use methotrexate. Plus, of course, I need highly active antiretroviral therapy for all these patients. For all these patients, I need HRT. Here, the main treatment will be itself HRT only. Plus or minus, I can use pseudophore if it's a progressive multifocal leukoencephalopathy. I think that should be easy. It's not a big deal at all. So we know how to differentiate all these three conditions: toxoplasma, primary CNS lymphoma, and progressive multifocal leukoencephalopathy. If somebody asks you most common cause of focal neurological deficit in HIV patients, answer will be toxoplasmosis. Somebody asks you most common cause of seizures in HIV patients, answer is toxoplasmosis. If somebody asks you most common cause of space occupying lesion in the brain in HIV patients, again answer is toxoplasmosis. That's all. So all these questions have been asked in the past, and I don't think really most commons will be asked anymore, but you might get other things, whatever I told. So most common cause of SOL, FND, seizure in HIV patients is of course going to be toxoplasmosis only. Okay. How to approach a space occupying lesion in HIV patient? So whenever I see a space occupying lesion in HIV patient, so in this setting, the first step is start with an empirical toxoplasmosis treatment. So I'll be starting with sulfamethoxazole pyrimethamine combination. So see whether it responds or it is not responding. If it's a good response, then continue same regime, continue treatment and finish off the treatment course. If it is not responding, in this setting, I can go for a stereotactic brain biopsy. Because here my another diagnosis, primary CNS lymphoma, do a stereotactic brain biopsy. So in this setting, if my brain biopsy is showing tachyzoids of toxoplasmosis, then of course I'm going to continue with the treatment and complete it. If it's showing more of a small blue round cell tumor, so it's a suggestive of primary CNS lymphoma, then in this setting I'll be starting with dexamethasone and methotrexate, and along with that HRT of course. So here, yeah, along with it I'll start HRT anyway. So if I write here, I don't want to write here, isn't it? So I can rub here. Okay, steroids plus methotrexate. But the most important point here is to know that steroids should not be given in the empirical treatment. That's very important, because whenever it's a common practice that if you see a space occupying lesion in the brain, immediately you start with steroids, dexamethasone. That's not a good idea to start dexamethasone here, or any other steroid for that matters, because in case there are many reasons for that. In case if it's going to be a like lymphoma, sorry. In case if it's going to be a lymphoma, then giving a steroid may be harmful in that setting, because I mean, suppose if you want to make a tissue diagnosis, it's not possible, because giving a steroid at the beginning itself, in case if it's going to be a primary CNS lymphoma, you might result in necrosis of the tumor, and if you take a biopsy, you will not be seeing anything else except for the necrosis. So tissue diagnosis will become completely impossible if you give a steroid upfront. Your tissue diagnosis may not be possible at all. So that is why giving steroids upfront should be completely avoided, and it's better to give steroids only after tissue diagnosis in this setting. Don't give steroids. And you might be wondering why we start dexamethasone. I told you, dexamethasone in the setting of raised ICP due to space occupying lesion is very good, because space occupying lesions are going to produce vasogenic cerebral edema. We discussed in stroke itself. That's why I prefer dexamethasone. And why specifically dexamethasone, if you ask? Dexamethasone is specifically preferred because it has a higher brain penetration compared to that of other steroids. For example, why not prednisolone, why not methylprednisolone? Because they are having a lower brain penetration. Dexamethasone has the highest brain penetration among all the glucocorticoids. That's why for brain purposes, we generally use dexamethasone, not other corticosteroids. All right, so this is how you're going to manage a space occupying lesion in the setting of a HIV individual. So fine. Okay. Similarly, if they ask you the treatment for neurocysticercosis, remember in exam, neurocysticercosis, not a very common entity. So most commonly, neurocysticercosis will present with multiple ring enhancing lesions in the brain, and usually they will present with seizures only. That's the commonest presentation of neurocysticercosis. You can remember Leander Paes. Leander Paes also had neurocysticercosis, and he actually developed seizure. And I'm not going to tell about the microbiology right now, because this is not worth right now. So you can study in microbiology. So they're going to have the seizures as the most common presentation, and they'll be presenting with multiple ring enhancing lesions in this setting. Then MRI or any, investigation we already told, multiple ring enhancing lesions, and most of the times you might be seeing in the ventricles also. So CSF cysts are also very, very common. So you'll be seeing some cysts, like going in the ventricles. So that's fine. And apart from that, treatment-wise, there is another question in neurocyst sarcosis where you'll be using albendazole as a very important treatment, but you don't give that 400 milligrams stat dose and all. That's for deworming. As far as NCC purpose, you have to give 10 milligram per kilogram of albendazole, high dose albendazole, at least for 21 days. Plus or minus dexamethasone in case if the patient is having mass effect. The patient has any mass effect surrounding edema, you can use dexamethasone as a cover-up because they are at high risk of seizures. If not, you can just give albendazole. That's going to be more than enough. Remember, the commonest presentation is seizures, and they're going to present again with multiple ring enhancing lesions, and some of these ring enhancing lesions can be seen in the ventricles. If they ask you where you won't start albendazole, that's also one question. Once upon a time, they asked in names where you should not start albendazole or where you should defer albendazole. What is the example? There are two areas where you don't really start with albendazole, despite the fact it may be neurocystic sarcosis, but what are the conditions? Anyone can tell? Can anyone tell? What are the two areas? One, dead cysts. So what do you mean by dead cysts? Dead cysts means completely calcified cysts. So usually they present with seizures. Of course, they can come with seizures. So a completely dead cyst, which is fully calcified, you need not start with albendazole. In that setting, you just start with anti-epileptic drugs. That's more than enough. Number one. Second condition, if the patient is having a severe encephalitis or a retinitis, retinal cysts. That's why fundus examination before starting albendazole is very important, because the dissemination can happen and they can come into the eyes also, retina. Whenever you start with albendazole, if it's an active cyst in the retina or if it's a severe encephalitis, so in that setting, giving albendazole might destroy this cyst, leakage of contents, produce more reaction, and they can result in even blindness and worsening of encephalitis. So if you have severe encephalitis or retinal involvement or eye involvement with neurocyst sarcosis, then in that setting, it's better to defer albendazole. In that setting, start with dexamethasone for some time, reduce the inflammation, then slowly give off the steroids. In fact, some authorities tell that for retinal cysts, it's better to do an ocular surgery and remove those cysts manually. Then you start with albendazole, because there is always a risk of developing blindness with the eye involvement. And severe encephalitis, once again, start with steroids first. Then you can go for slow titration of albendazole over a period of time. So nevertheless, this diagnosis this treatment has been asked multiple times. Albendazole 10 milligram per kilogram for 21 days. And together you can start with dexamethasone if you want. And it will also present like a ring enhancing lesion. And they have ventricular cysts also. That's one of the characteristic key finding in the neurocercosis. And one of the important differential diagnosis is tuberculoma. It's very difficult to differentiate from a tuberculoma. So the only way to differentiate is MR spectroscopy. MR spectroscopy reliably can differentiate a neurocyst sarcosis from a tuberculoma to a great extent. So where there'll be a flat lipid peak and a choline peak, whereas in tuberculoma you'll have a lipid peak and a choline peak. And that's beyond the discussion. Anyways, if they ask you how will you differentiate between a tuberculoma and a neurocyst sarcosis, I generally go towards a MR spectroscopy. That's investigation. And MRS is not only to differentiate tuberculoma for neurocyst sarcosis, it can also be used in multiple cancers also. If you suspect a cancer in the brain, so certain types of cancer will show certain specific findings in MRS. So depending on what metabolites they produce, you can get certain MRS metabolite peaks in that tuberculoma. But neurocyst sarcosis will not show any peak. It will be flat. So that's a characteristic feature of a neurocyst sarcosis. Tuberculoma will show typical choline and a lipid peak. So fine, MRS is the way to go there. If you differentiate NCC versus tuberculoma. For other cancers also, you can do MRS. It's not only for this. MRS is useful for other CNS cancers as well. I think this is extremely high yielding information, whatever I told you till now. And you will be able to answer almost all the questions on CNS infections. So I'll tell a short note on certain CNS tumors till that. So just I'll put a table because I need to finish off faster and I need to tell only the high yielding information, isn't it? Whatever you need for exams. So There are childhood tumors and there are adult tumors. First, we'll start with the childhood tumors. So, I mean, if you want to put what is the most common, of course, whenever you think about a CNS tumor, every student asks only one thing: what is the most common? What is the most common? What is the most common? In that setting, children I can put separately, adults I can put separately. In adults, metastasis are going to be the most common tumors, and primary tumors means if they ask you the most common primary tumor, I will answer it's a meningioma. That's the most common primary tumor in adults. And if they ask you most common malignant tumor, most common malignant specifically, remember most common overall tumor or most common primary tumor is always meningioma only in adults. Most common malignant tumor is GBM, that is glioblastoma multiforme. But overall most common is METS. Primary most common is meningioma. Primary most common malignant is glioblastoma multiforme. In children, remember primary tumors are more common than metastasis unlike adults. That's really, really important point. And at the same time, in the primary tumor, if they ask you what is the most common, it's astrocytoma. That's the most common. Typically, something called a juvenile pilocytic astrocytoma. That's the most common primary tumor as far as children is concerned. Clear? Metastatic tumors are extremely rare in children. You don't really get metastatic tumors. And more importantly, majority of the tumors, childhood tumors, tend to be infratentorial, which means it will be below the tentorium cerebelli. Majority of the tumors in children will be infratentorial nature, whereas in adults, majority of the tumors will be supratentorial, above the tentorium cerebelli. Suppose if they ask you most common supratentorial tumor in children, I mean, you know it's infratentorial, but if it's a supratentorial tumor in children, most common supratentorial tumor in children will be craniopharyngioma. Craniopharyngioma is a most common supratentorial tumor in children. Apart from that, I think majority of the tumors, all the tumors in children will be infratentorial only. Almost 90% plus tumors in children will be infratentorial location, which means they will be involving the cerebellar region. That's where the tumors in children is going to be. So this is the common classification. So if somebody, like who's preparing for postgraduate entrance want to know the most commons, this table will be helping you. And apart from this, I can put a small table again, where I can tell the tumor, basically. What is the tumor precursor? Thus I can tell the tumor and I can tell the precursor from where it is originating from. Then we can write the typical lesion. So typical location that's going to be there. And finally, you can tell the histological findings also, right, separately. So first we'll finish off the childhood tumors. The first childhood tumor is pilocytic astrocytoma. Remember, knowing the entire WHO classification has absolutely no sense in exam, and nobody is going to ask the full WHO classification for CNS tumors. If you have interest, you can learn, but according to me, for exams, it's not going to be of any worth at all. You're only going to kill time and you're going to only confuse yourself. So first is pilocytic astrocytoma. You know the precursor is going to be astrocytes. And typical location of this tumor is in the posterior cranial fossa. We know it's infratentorial. Posterior cranial fossa, infratentorial location. And typically it will be arising from the lateral hemispheres of the cerebellum. Very common site of origin is the lateral hemisphere of cerebellum. Of course, whenever it originates from the cerebellum, means they're going to have ataxia and cerebellar dysfunction will be there, cerebellar signs will be there. And they might be having obstructive hydrocephalus because the fourth ventricle is near the cerebellum, isn't it? The third ventricle through the aqueduct of Sylvius connects to the fourth ventricle. So in that area, if the tumor comes, they'll produce obstructive hydrocephalus. And at the same time, they can produce herniation and respiratory failure and death. So these will be common features for any childhood tumor. So no need to tell again and again. So what are the common features? One is the hydrocephalus. Because of the obstruction to the CSF flow, it will be an obstructive hydrocephalus. Second is going to be the cerebellar dysfunction. And of course, mass effect like headache and raised ICP features like papilledema can also be there. But usually, any child in exam who's coming with ataxia, headache, and hydrocephalus, it's a deadly combination. You have to think about a tumor because it's an infratemporal tumor that you're dealing with. And you know what you see in the histology, you typically see something called Rosenthal fibers, even though it's not specific. These are eosinophilic fibers, which will be having a corkscrew appearance. Corkscrew eosinophilic fibers. You can go back and see in the Robbins pathology, exact same description. Corkscrew fibers with eosinophilic appearance, called as Rosenthal fibers, not very specific. And more importantly, AIMS questions will be asking you this, that will be GFAP positive. That is glial fibrillary acid protein will be positive in this tumor. That's how they frame the question. So that's pilocytic astrocytoma. And next we have a medulloblastoma. It's also a childhood tumor, and more importantly, medulloblastoma is more of a peanut. So what is peanut? This is a primitive neuroectodermal tumor, which means they can also show the typical small round blue cells, because peanuts, this is a primitive neuroectodermal tumor. And then what will be the characteristic location? Typical location will be in the cerebellum, but it will not be in the lateral hemispheres. It will be more in the midline. So midline cerebellum near the vermis. So that is where your location will be. And one important, thing that to note about this medulloblastoma is the ability to produce something called drop metastasis. Everyone knows what you mean by drop mets because of their ability to spread via CSF. That's called leptomeningeal seeding. Very, very high with medulloblastoma. They can seed through the entire CSF and entire meninges can be involved. So that's called drop metastasis, and because of that, they can cause some spinal cord issues like paraplegia because of the CSF spread. So that's a very important point. Apart from that, histology-wise, they are going to produce small blue round cells, same SBRCD, small blue round cell tumor. And more importantly, there is one more point that points towards that in exam is Homer-Wright rosettes. You would have studied in pathology. What are the rosette types? One of the important rosette types is this Homer-Wright rosettes. And another area where you see rosettes is your retinoblastoma. You go back and study in ophthalmology or in the pathology. So medulloblastoma. And third thing is ependymoma. Ependymoma. As far as ependymoma is concerned, the origin will be ependymal cells, and location will be in the fourth ventricle, typically floor of the fourth ventricle especially. And typically in the setting of histology, you'll be seeing this perivascular rosettes. So this perivascular rosettes will be the clue in exam. A tumor will be originating from the fourth ventricle. And we have a pinealoma. Pinealoma, we know it's going to origin from the pineal gland epithelial cells. And the location will be near the dorsal midbrain. Because they compress in the dorsal midbrain, they can produce Parinaud syndrome. The clinical features may be very similar to that of Parinaud syndrome, which I have discussed already. And one of the important histological features is the presence of this fried egg cells in this tumor. Fried egg cells. These are nothing but large vacuolated cells with a lymphoid stroma. There will be big vacuolated cells with lymphoid stroma. That is what we refer to as a fried egg cell. Clear? So, and again, it's a non-specific finding. So don't think whatever findings I've told you are specific. In the context of the clinical feature, whatever I told you, if you see this kind of histological finding, that goes towards that particular tumor. That's all. But these findings can be seen in many other places also. And now we are moving on to the adult tumors. The moment you think about adult tumors, the first adult tumor that you have to encounter in exam is GBM, that is glioblastoma multiforme. Typically, this is an old age tumor, which means it happens after 50 years. One of the very common tumors in old age, brain tumors. And the origin is from astrocytes. And the location will be in the cerebral hemispheres. That's where the location is. Very commonly in the frontal lobe. That's where the location will be. Usually it starts unilaterally. And it can move bilaterally because of the white matter spread. It spreads through the white matter. Through the axons of the white matter, they spread to the other side also. And one of the important reasons for white matter said is corpus callosum. They can spread through the corpus callosum and other association fibers and other commissural fibers, and they can move to the other side. And typically, once it moves to the other side, they characteristically produce that sort of a butterfly shape. And like every second year, third year, if you ask butterfly tumor in the brain, they will tell it is a glioblastoma multiforme. It's a butterfly glioma because of the bilateral spread through the white matter across the corpus callosum and association fibers, producing a butterfly shape on both the sides. So that's a butterfly glioma. And as far as histology is concerned, the most important point is the pseudo-palisading arrangement. So any neurological tumor, if they tell pseudo-palisading, it is glioblastoma multiforme unless proved otherwise. Plus, typically they will show this central necrosis, and this also will be GFAP positive because they are astrocytomas. That's why. See, remember, in adults, GFAP positive goes towards a GBM. In children, GFAP positive goes towards a pilocytic astrocytoma because both are originating from the astrocytes in this regards. One probable reason. And this word is very, very important. Multiple times asked question, pseudo-palisading element. And of course, in pathology, they will describe in great depth and detail about what is pseudo-palisade, what is a true palisade. Yes, what are the layers that form the pseudo-palisade? So you can go and study there. But as far as I know, I think in the future, exams are not going to ask really how pseudo-palisading is formed. They're going to ask only pseudo-palisading means where. That is glioblastoma multiforme in adults. That's all. Then you have a meningioma, benign tumor. It's not a malignant tumor, of course. As far as meningioma is concerned, it's going to originate from the arachnoid layer of the meninges. So this is a very important question in exam because nobody knows which layer of meninges the tumor is originating from. Many students don't know that's an arachnoid layer. And there are multiple things that you need to know about this meningioma. It's the most common extraaxial tumor. So what do you mean by extraaxial tumor? So whenever you talk about an extraaxial tumor means it's outside the substance of the brain. So that's what we call as an extraaxial tumor. The most common extraaxial tumor is always meningioma. And most common extraaxial tumor in adults, meningioma. But if I ask you most common extraaxial tumor in children, answer will be craniopharyngioma. Most common supratentorial tumor in children, craniopharyngioma. Most common extraaxial tumor in children, craniopharyngioma. Most common extraaxial tumor in adults, your meningioma. Most common benign tumor in adults, benign primary tumor in adults or benign tumor in adults, again meningioma, no doubt about that. It's going to originate from the arachnoid area. And so what are the imaging findings? What I'm going to see, it is extraaxial, outside the substance of the brain. So what is the location? Location characteristically, most common location will be parasagittal location. Parasagittal means in the falx cerebri. So falx cerebri folds like this in the center. So that area, that parasagittal region, that's the commonest location for a meningioma. Apart from that, it can happen in the cortex, or we can write cortical convexities, cortical locations. And you can have a skull-based meningioma also. It's very difficult to treat. Operation is also very difficult, skull-based meningioma, but usual location is the parasagittal location. Or cortex convexities, or I can write cortical convexities, second. Next followed by cortical convexities. Then followed by skull-based meningiomas. And this extraaxial location should be confirmed with imaging. And definitely they will ask you what are the features of this extraaxial location of the tumor. In MRI, you will see some characteristic findings. Everyone knows that who has 100 radiology sessions. So you'll be seeing something called a CSF cleft and a dural tail. Whenever this sees this form of a CSF cleft and a dural tail, which means this tumor will be attached to the meninges with the form of a cleft-like substance. It's a tail-like thing. This is a dural tail basically. So which means when the tumor grows, like from the arachnoid layer, when they grow out, they take a part of dura like a tail along with them. So that's a dural tail basically. And at the same time, there will be some form of CSF that is loculated between the tumor and the other areas. So that is because it's coming from the arachnoid once again. So this is called a CSF cleft and a dural tail. So very classical of a meningioma. Or it can be seen in any extraaxial tumor for that matters. So then in MRI, if you see the enhancement pattern, as far as the enhancement pattern is concerned, mostly it will be homogeneous enhancement, which means there will be uniform enhancement throughout, and that's a homogeneous enhancement pattern that you're going to see. And typically, as far as the histology is concerned, you will be having this kind of spindle cells in whorls, and plus or minus they can have psammoma bodies. You know, meningioma is one of the important area where you can see psammoma bodies. We know that because in exam, whenever they give psammoma bodies, there are 3 tumors which you have to diagnose. One is meningioma, next is serous cystoma of ovary, and third is papillary cancer of the thyroid. Many other cancers can also show, but these 3 are classic tumors in exam where you have to answer for psammoma bodies: meningioma, serous cystoma of ovary, and papillary cancer of thyroid. And more importantly, how they will clinically present, depending on whether it's slow growing or fast growing. Slow growing tumors, usually they present with seizures. That's why you have to remember slow means seizures, S for S. That's how they come. Suppose if it's a fast growing tumor, they will come with a headache plus or minus a focal neurological deficit, but very rare. Usually meningiomas are known to be benign and they will be slow growing only. And the most common presentation will be seizure only, if they present. And if they ask you most common way of diagnosing meningioma, it's incidental. You do MRI for some reason, you pick up meningioma incidentally. So that's how you pick up. But if they come with some symptom, most common symptom will be seizure only. That's how they present, because most of them will be slow growing tumors. And one more important fact is meningiomas can be PR positive, that is progesterone receptor positive. They can have a PR positivity, that is progesterone receptor positivity. That's dangerous because giving any progesterone containing pills or giving, during pregnancy especially, they can grow rapidly, rapid growth. They can grow rapidly, very, very fast, and they can become a symptomatic meningioma. So that's very important. And if they ask you one of the important mutation that is associated with meningioma in these tumors, that's NF1 deletion. NF1 gene deletion, that's also a very important point. Because it's quite common, they will ask you a lot of questions on this. Treatment is surgical resection. Of course, it's very easy to remove this tumor because most of them will be extraaxial. Just you put a cut, it's going to come out easily and you're going to remove that tumor. And the skill of the neurosurgeon rests in treating a skull-based meningioma. That's very difficult to treat. Second, treating a meningioma in such a way that the recurrence won't happen. So these are the difficult things, and this tells you the skill of a neurosurgeon. But meningioma as such as a whole is easy to treat basically because it's outside the brain substance only. So not a problem. So what are the points here? NF1 gene deletion, extraaxial, benign, then progesterone receptor positivity, rapid growth in pregnancy, presence of psammoma bodies, most common location parasagittal, and these findings of extraaxial tumor, and slow growing, seizure as a most common presentation, and layer of origin is arachnoid layer. Very important points with regards to meningioma. And the 7th tumor that we are going to discuss is going to be hemangioblastoma. Hemangioblastoma. So very commonly in exam, whenever you see a brain tumor that is associated with the polycythemia, because it's one of the important paraneoplastic syndromes, and many problems like Van Hippel-Lindau syndrome also can produce hemangioblastoma, can be associated with polycythemia. So any neurological tumor, if you see with polycythemia, think about hemangioblastoma in exam. So that's the clue there. And apart from that, origin will be from the cerebellum mostly. And it's a vascular origin tumor. The name tells you it's coming from the vessels, hemangioblastoma. So common location is going to be the cerebellum, which means infratentorial location, even though it's common in adults. It can be associated, as I told you, with Van Hippel-Lindau syndrome, VHL. You know, the VHL gene is present chromosome number 3, and Van Hippel-Lindau syndrome is separate, like neurocutaneous syndrome. And as far as MRI is concerned, most often they'll be having a cystic appearance. That's a key here, cystic brain tumor, which means it will be watery. And if you take this thing, you'll have a black shaped, black colored tumor because it's water, it's cystic, and you will have a mural nodule. So this is an enhancing mural nodule. This is a whitish enhancing mural nodule. So whenever you see this kind of a mural nodule, word in exam, that's a direct pointer towards the hemangioblastom, because this is the area where tumor is located at a concentrated entity. And the skill of a neurosurgeon again rests in removing that mural nodule carefully, because when you puncture this tumor, it will release the cystic content. And after that, to search for a mural nodule becomes very difficult, really. That's why if you don't remove the mural nodule properly, the tumor will come back again and again. So that's why removing that becomes really difficult, even though this is a very simple tumor. So, but in exam, if you see this enhancing mural nodule with the cystic appearance of the tumor, then it goes towards a hemangioblastoma. And of course, what you're going to see in histology, it's densely packed capillaries, that's all. Dense, thin-walled capillaries, densely packed, thin-walled capillaries, fragile capillaries. That's what you're going to see in this tumor. That is hemangioblastoma. So here the key point will be that mural nodule. That will be the clinching point for diagnosis. Then you have vestibular schwannoma. Vestibular schwannoma. Remember, this is the second most common extract cell tumor in adults. First most common extract cell tumor in adults is craniopharyngioma. Second most common extract cell tumor in adults is vestibular schwannoma. Remember, there is a considerable confusion whether it's inferior vestibular nerve or superior vestibular nerve. And anytime whenever I discuss this vestibular schwannoma, they ask whether it's inferior vestibular nerve or superior vestibular nerve. This kind of discussion should be strictly avoided. And it's been told by many books it's coming from inferior vestibular nerve only. But again, I don't think that that's going to be a question anytime in the future, because now they're moving ahead of these kind of questions. Don't break your head based on that. Typically, they originate from the Schwann cells. That's the cell of origin. And where the tumor origin will be in the CP angle. CP angle. And the most common presenting feature will be deafness. Many people will think eighth nerve involvement and vestibular problem will be the common. No, but this tumor typically comes with the deafness, not with the vestibular issue predominantly. And remember, this is an extract cell tumor. So that's why I told you that second most common extract cell tumor is vestibular schwannoma. And you know the gold standard, many times asked question ENT, that is MRI with gadolinium contrast. Like MS, this is also MRI with gadolinium contrast, which becomes the gold standard investigation. And this is a tumor that originates from the CP angle. Any tumor in exam originating from cerebropontine angle, in adults, think about a vestibular schwannoma. And of course, you will see spindle cells in palisades. Remember, but these are true palisades, not our pseudo palisades. That's the main difference. So that's why I told you that point pseudo palisading is important, because that goes towards a GBM. And this kind of true palisading arrangement that is seen in vestibular schwannoma is what we refer to as Antoni pattern. One of the questions in exam, at the same time, this areas of palisades will alternate, which means one area will be palisades, another area next to that will be myxomatous areas, or myxoid areas will be there. So this alternating myxoid areas is what we refer to as Antoni B pattern. And more importantly, these tumors will be S100 positive. Even pheochromocytomas can be S100 positive, that doesn't matter. So it's not specific, but in the brain, if you get a S100 positivity, you think about a vestibular schwannoma. And finally, the last tumor I'm going to discuss is on oligodendroglioma. Oligodendroglioma. It's going to originate from oligodendrocytes. We know that. And typical location will be in the frontal lobe. And finding again will be fried egg cells, fried egg kind of cells. We saw what is fried egg cells already. And more importantly, other things that in exam will be a clue for this diagnosis: chicken wire appearance. Chicken wire appearance or chicken wire pattern, which is basically a pattern of capillary anastomosis. Chicken wire pattern of capillary anastomosis. So this will be the key point in exam. And presence in the frontal lobe. Key point. Clear? These are the 9 tumors I want to tell, and very high yielding. And I think the 10th tumor is there, primary CNS lymphoma. I thought I discussed there, but let us finish off. You have a primary CNS lymphoma also. Of course, the tumor of origin is lymphocytes, and we know that it's a DLBCL. So it will be coming from B cells. It's a B cell lymphoma. Primary CNS lymphoma is a B cell lymphoma, basically. So we know where it's going to originate. It's going to be present in the deep white matter near the frontal lobe, very common location, frontal lobe. As far as MRI is concerned, remember immunosuppressed people and immunocompetent people will be having different picture. Immunosuppressed people will immunocompetent people will have usually a solitary lesion, single lesion with homogeneous enhancement, whereas in immunosuppressed people it will be more of lobulated appearance and they can be ring enhancing in nature. So there will be a lot of difference with immunocompetent and immunosuppressed people as far as this thing is concerned. And if you take the EBV serology is positive in more than 95% in immunosuppressed people. Immunocompetent people, EBV serology will be positive only in 5 to 20%. So EBV serology is very important in exam if they want to give about a primary CNS lymphoma. And of course, histology we know already. It's a small blue round cell tumor, SBRCT, and other features of DLBCL will be there. Fine. Of course, all these tumors, whatever may be the tumor, from the beginning, whatever may be the tumor, the treatment of choice is neurosurgery, where you tend to remove the tumor. Treatment will be surgery only. You remove the tumor. Of course, that's the most important aspect. And what they will, for any primary tumor. But if they ask you about mets, what you will do, whether you will resect or you will not resect. So you can resect if the patient is having a single metastasis, plus if the patient is surgically fit also. You can attempt a resection, even in the case of mets. I mean, many times it will not be possible because the mets will be multiple or the patient will be completely surgically unfit. So in this setting, you cannot do. The patient is surgically fit, plus if there is a single metastasis, maybe you can attempt a resection in that setting. But otherwise, resection cannot be done. And second question, what they will be asking you is where will you use something called a prophylactic cranial irradiation? Where you can do that. It's very easy, like very common question. It's an age-old question. And so that you are going to answer. Where are they? I'll take some rest for my fingers. Where will you use prophylactic cranial irradiation? Yes, two areas. One is you can use that in the setting of small cell lung cancer. Remember, prophylactic cranial irradiation should be used only. Okay, screen down. Okay, prophylactic cranial irradiation can be used only if the patient is not having any like cerebral metastasis. If the patient is already having cerebral metastasis, then there is no point in using prophylactic cranial irradiation. So in that setting, please don't use prophylactic cranial irradiation. The two tumors is, one is ALL, acute lymphoblastic leukemia, and second is small cell lung cancer. Medulloblastoma, previously it was done, but right now we don't do for medulloblastoma, even though they have a rapid risk of CSF seeding, but we don't do it. But for SCLC and ALL, standard indications. But remember, before giving this, always rule out metastasis, metastatic disease. If there is already a metastasis, then there's no point in giving a prophylactic cranial irradiation. Then it will become a therapeutic. That's different. So prophylactic cranial irradiation can be done only after ruling out metastasis in a patient with SCLC or probably with a acute lymphoblastic leukemia, ALL. Do you understand? Clear not? I think whatever the important points that I've told you, it's like a power pack session only. I've told you whatever is important for your exams. I think this will give a good idea about what all to study and what not to study. And don't break too much about this, CNS tumors and all, because they are very low yielding areas. If you get 1 point, most commonly it will be from whatever I've told you till now. And there is a 95% plus chance to crack the question from CNS tumors if you know this 10 tumors, whatever I told you, and their findings. To get that extra 5% probability, don't waste like 5 days, 3 days on only CNS tumors, because it's very big, it's huge. You cannot really complete CNS tumors at any point. There will be always, there will be some point that is coming up. It's one of the huge area, and that's a complete neurosurgery area. Don't think too much about it. And another upcoming area that you might get in exams is the PNS, paraneoplastic syndromes in CNS. So what are the paraneoplastic syndromes that you can get? It's a very upcoming area. So I'll tell you only selected things with regards to PNS, I mean paraneoplastic syndromes. One is what is the antibody associated with what cancer, what tumor, and you can see the PNS, the effect, paraneoplastic syndrome that you're going to get. First one is the anti-HU antibody, that is anti-HU antibody. So this is also called as ANA1, otherwise referred to as ANA1, anti-HU antibody. So the usual tumor of origin is small cell lung cancer, so SCLC. So usual tumor of origin. Typically they tend to produce cerebellar degeneration. I'll tell only the selected points. There are more than 25 antibodies are there. Only selected important antibodies I'm telling. Cerebellar degeneration, then they can produce limbic encephalitis. I think I've told something about this already. Then they can produce neuropathy. But as far as I know, in exam, this limbic encephalitis word is going to be the most important with regards to anti-HU antibody, that is ANA1. Then we have anti-RE antibody. This is otherwise referred as ANA2, anti-RE antibody. And the tumor of origin is typically the lung and the breast. So these are the two tumors that can produce this anti-RE antibody. And they typically produce cerebellar degeneration. And third one is anti-YO antibody. That's really, really important antibody. If at all there's one antibody that you should never forget in exam, that is anti-YO antibody. Anti-YO antibody is otherwise referred to as something called anti-Purkinje cell antibody 1. Purkinje cell antibodies of the cerebellum. So it's an anti-Purkinje cell antibody. Typically damage the cerebellar peduncles. So that's why they will result in cerebellar problems. Typical origin is gynecological cancers like breast and ovarian cancers, very common in females. So as the name suggests, Purkinje cell antibody of the cerebellum, so they're going to produce cerebellar degeneration. This is an exclusive antibody that produces cerebellar degeneration, which means it doesn't have any other effects apart from cerebellar degeneration. So that's why this is very, very important in exam. So anti-YO antibodies. Females coming with weight loss, cerebellar problem, think about anti-YO antibody. It was one of my MRCP questions once upon a time. So a female coming with a weight loss or an ascites or a breast mass having severe ataxia, think about anti-YO antibody. The next step is to find out anti-YO antibody. They will ask you in that setting also. They can form any clinical scenario, which is valid. So anti-TR antibody, next one. So anti-TR antibody typically seen in Hodgkin lymphoma. Once again, they are going to cause cerebellar degeneration. Hodgkin lymphoma. Number 5, we have anti-amifacin antibody. Anti-amifacin antibody typically will be coming again from lung and breast cancers. And this has been asked in JIPMER once. That's going to produce something called a stiff person syndrome. Stiff person syndrome or a stiff man syndrome, anti-amifacin antibodies. This is a JIPMER question already asked. I think in 2016 or 15, I don't remember exactly, 16 I think they have asked anti-amifacin antibodies. And we have anti-recoverin antibodies, otherwise referred to as anti-CAR antibodies. Typical tumor of origin is small cell lung cancer, typically results in retinopathy, vision problems. And 7th, you have anti-acetylcholine receptor antibody, happen in the setting of a thymoma, and we know what's going to be the effect it's going to produce, myasthenia gravis. And finally, 8th one, we have anti-VGCC, that is anti-voltage gated calcium channel antibodies. We know SCLC again produces LEMS, Lambert-Eaton myasthenic syndrome. So you have plenty of antibodies, some 8 to 10 antibodies are there basically. More, which I'm not told yet, but I think if I tell everything, then that will not be a high yielding session anyway. So that's waste. So these are the 8 antibodies that you need to know for exams: anti-HU, anti-RE, anti-YO, anti-TR, anti-amifacin, anti-recoverin, acetylcholine receptor antibody, and anti-voltage gated calcium channel antibody. Of course, the most important of all will be the anti-YO antibody only, because that's been asked multiple times in the past. At the same time, anti-amifacin antibody also has been asked already. which produces stiff person syndrome, and anti-VGCC is a very common entity. It's been asked for almost 20 years down the lane. That is LEMS, Lambert-Eaton myasthenic syndrome. Do you get it? I think it's almost over. Whatever is left, if you want me to tell, I will tell. Otherwise, we'll start tomorrow with a new topic. Maybe whatever you want, maybe rheumatology or nephrology, what you want, we'll start. No problem. I think we have covered a little bit of decent stuff in this session. All right. Okay. Brief of seizures. Okay. If you want briefly, I will tell briefly. But I don't want, I think we need not select. Parkinson is a waste disease, man. It's something which is understood by everyone. Advance happy birthday. Hari is telling now. My birthday got over yesterday, Hari. Sorry. Okay, we'll start tomorrow morning. Okay, so whatever is left, I will do. Only little is there. But tomorrow, you tell me whether to start rheumatology or whether to start nephrology. So whatever we want, we'll start. No problem. You want, I mean, many are commenting rheumat, nephro, rheumat. So, okay. So fine. So tomorrow then, because it's a mixed idea about rheumat versus nephro. So because half nephro, half rheumat, I will decide what to start tomorrow. Okay. Bye-bye. See you. Anyway, I'll tell the extension of the class when the class will be extended, because I don't think we can finish in the next 3 days. So definitely class will be extended by another 3-4 days. Yeah, 11 is asking EEG. EEG will be coming in seizures only. Anyway, class will be extended by 3-4 days. I'll do it later on. Maybe in October 1st or 2nd week, I'll try to do again. Whatever is possible, we'll finish in the next 3 days. Bye-bye. Anyways, good night. We have to complete the syllabus. Bye.